My name is Barry Love. I'm an assistant professor of cardiology and director of the congenital cardiac catheterization lab at Mount Sinai Medical Center. And with me today is Dr. Lili Ostojic, who is assistant professor of neurology and assistant director of the telestroke program, and someone with whom I collaborate very closely with my PFO stroke patients. We are going to review the current guidelines and landscape for PFO closure, and then Dr. Ostojic is going to talk about the shift in her practice and insights from a neurologist. And then we'll talk a little bit about the cardiology considerations in patients greater than 60 years of age, and then we'll have a bit of a discussion. So for the introduction, PFO closure in patients greater than 60 years of age, where are we? So I'm a proctor and consultant for Abbott Laboratories. So we'll talk about the background. So patent foramen why do we have one at all? So first of all, there's an association between cryptogenic stroke and patent foramen, especially in patients that are less than 60 years of age. And the mechanism of stroke is postulated to be paradoxical embolism of venous thrombus through the PFO to the cerebral circulation. And it's been reasoned that PFO closure should decrease the recurrent stroke risk in those who have had a first event, that is secondary prevention. Why do we have a PFO at all? Well, again, before we're born, we get our nutrients and oxygen from our mother that comes back through the umbilical vein, and that's directed across the foramen ovale to the left atrium, left ventricle, to the head, so that before we're born, our head gets the most oxygen, nutrient-rich blood. The more deoxygenated, nutrient-poor blood is coming back from the IVC and the SVC, goes to the right atrium, right ventricle, pulmonary artery, but then goes down the ductus arteriosus, where a proportion of it goes to the umbilical arteries to get oxygenated by the placenta. What happens with the foramen ovale after we're born? The umbilical cord is cut. We take our first breaths, blood rushes into the left atrium and is no longer coming across from the umbilical vein, and the PFO functionally closes, and in most of us seals shut. But in a good proportion of people, up to about 30% of adults, continue to have this potential trapdoor, the foramen ovale. Again, the fate of the foramen ovale, as you can see, about a third of them remain patent, and in an autopsy study, you see the prevalence that's found, and it's about 30% in adults. Just to discuss terminology, an atrial septal aneurysm is where that septum primum is very mobile, more than a centimeter. It means that the door basically can open much more. Now, you can have an atrial septal aneurysm in the absence of a PFO, but it's actually very commonly found with a PFO, and that means that the door can open more significantly and typically is considered to be what we call a high-risk PFO. We'll talk about that a little bit more later. It seems to be a higher risk for recurrent event, and some may be a little bit more difficult to close percutaneously. How do we diagnose a PFO? Well, the transesophageal echocardiogram with a Valsalva maneuver is considered to be the gold standard, and here you see an image of that. A transthoracic echo is less sensitive, but again, if you have a positive study by transthoracic echo, you can typically use that. You can use that data. We as well, we'll use a transcranial Doppler often, and we do this with a probe on the head, and we'll inject agitated saline in a peripheral vein. And most of the time, again, in a normal circumstance, those microbubbles are filtered out by the lungs. In someone who has a PFO, especially if you do a Valsalva, those bubbles can go across the foramen ovale and are seen in the hits. In the cerebral waveform when we see it on the transcranial Doppler. And the nice thing about this is we can do this in the office with no sedation. Again, I will often use this where a patient has had a prior study that's maybe equivocal, or I don't have the data available immediately to see it, and this will confirm the diagnosis of a potentially significant right to left shunt. There's an association between cryptogenic stroke and PFO in young patients, and these are studies that were all in the in the 90s, the early and late 90s, showing the association between PFO and stroke compared to controls. In older patients, the incidence is a little bit less strong. The data is a little bit less strong. But there are still studies in patients greater than 55 years of age where, again, we're still seeing a significant difference. So association to causation. So PFO is found in between 15 and 30% of normals versus 50% of young patients with cryptogenic stroke. And the mechanism of stroke is presumed to be paradoxical embolism of venous clots. Again, this is a journal published article where you actually see a clotted transit going across the foramen ovale. Again, we rarely see that. Again, it's a little bit scary when you do see that, but we rarely see that, but this is the presumed mechanism. So what's the risk of a first stroke in patients with PFO? Well, the answer is that it seems to be not really any different than the general population. You could reason that in the sense that about 30% of people have a PFO, and if the risk of first stroke was significant in those patients, the ERs would be full of these patients all the time. Again, where in practicality, it's not that common an event. There was a study that was done in northern Manhattan, where we are here, that looked at this, and again, they found the PFO in about 15% of patients, and they were followed for almost 80 months, and the incidence of ischemic stroke was no different in PFO or non-PFO patients, or in the subset of patients that had PFO and atrial septal aneurysm. Again, the mean age of these patients was about 68 years of age, but again, you know, they're only been followed for 80 months. But the problem is that, you know, we know that there are these patients that have PFO, but until they've had a stroke, we really can't pull them out of the soup as being at higher risk. Now, once you have had a stroke in someone who has a PFO, their risk of a subsequent event is higher. And again, this was shown by Moss and others in the New England Journal in 2001 that showed, again, especially if you had a PFO and atrial septal aneurysm, that your incidence of stroke or TIA in the next 2 years was about 4.8%. So if you've had an event and you have a PFO, especially with atrial septal aneurysm, your risk of a subsequent event is significantly higher. So what have been the randomized device trials to date? So the first trial that I want to talk about is Closure 1, and this was 900 patients that were randomized 1-to-1 PFO closure versus medical therapy. And again, we're going back a fair bit of years. The first trial, the data for the trial was announced in November of 2010, and the paper was released in 2012. This is patients that were 18 to 60 years of age with cryptogenic stroke or TIA, and these patients were randomized to medical therapy versus device closure with a Starflex occluder, and they were followed for 2 years. And the trial ended 2 years later than expected and with half the planned enrollment. And here's the data. There were fewer events in the closure group than in the medical group, but the p-value was 0.37. So an almost 40% chance that this difference could be explained by chance alone. One of the biggest criticisms of this trial is that they were not selective enough in the patients that they included. Patients with lacunar stroke were included. And again, I think that a lot of the data was muddied by the fact that there were patients that happened to have a PFO that had other mechanisms of stroke that were included in that trial. Unfortunately, it doesn't come out very well here in the highlight, but many patients likely had an alternate etiology for stroke, and they did not exclude lacunar stroke, was again one of the biggest criticisms of this trial. The first positive trial was the RESPECT study. This was using the Amplatzer PFO occluder. And again, this was randomizing patients with PFO and stroke, not TIA. These initial results were announced at TCT in October 2012, and the first paper was published in 2013. So this is using the Amplatzer PFO occluder, which is the same device that we're using now. It's a percutaneous transcatheter device with self-expanding nitinol discs with polyester fabric. And it came in 3 sizes then, 18, 25, and 35. Nowadays, we have an intermediate size of 30 millimeter occluder as well. They did exclude many things that, again, would be alternate explanations for stroke, and they excluded lacunar stroke in that. Again, they included patients 18 to 60 years of age, and the limit was set at 60 years of age because, again, we were very interested at that time in trying to in trying to get a positive trial. By excluding patients that were older than 60, we were trying to exclude patients that had an alternate explanation for stroke, and age seemed to be a reasonable way to do that at that point. There were 980 patients that were enrolled, and again, basically randomized 1-to-1. The medical therapy arm was not randomized, about half the patients on aspirin, a quarter on warfarin, and then a smattering of other antiplatelet agents. And the study design was that it was going to be followed until there were 25 events, and it was powered for a 75% reduction with PFO closure. And here's basically the data. There were fewer events in the device group than in the medical group, but in the initial paper, the p-value was 0.08. And so we were quite disappointed with that. Having said that, again, there were only 25 events. And as it turns out, there were a number of problems. One patient had recurrent stroke after randomization, but prior to receiving a device. Another patient was randomized device and then refused to have one implanted. Another patient was randomized to PFO closure but then was found to have coronary artery disease, had a coronary artery bypass graft, and had a stroke peri-surgery, and again was classified in intention to treat analysis in the device group. And a final patient had a PFO closed, had a second stroke, and then was found to have a sinus venosus atrial septal defect. So in fact, the atrial septum wasn't closed. So when you looked at the data and analyzed the events that were patients that truly had closure in the device group versus the medical group, the p-value became very significant. Having said that, it was still not felt to be strong enough data at that point. There were very few complications in either group. Again, having said that, with the data that was presented, it was not considered to be a positive study at that time, but the patients continued to be followed per protocol. And in May of 2016, with a mean follow-up of 5.9 years as opposed to the 2.6 years at the initial study, there was another analysis. And again, those curves continued to separate. And even in the intention to treat group, we still had basically a 50% or 45% risk reduction with a p-value that was now significant. And with that, the Amplantar PFO occluder was FDA approved for patients in October of 2016. And again, at that time, the FDA approval is very interesting because, as they wrote, this was approved to decrease the risk of recurrent ischemic stroke in patients with PFO predominantly between the ages of 18 to 60 years of age. So they did not say firmly that 60 was going to be an absolute cutoff. Again, they do say that the presumed mechanism should be embolic stroke as determined by a neurologist and a cardiologist following evaluation to exclude known causes of ischemic stroke. And then that paper with that follow-up data was published in September of 2017, along with two other studies, the REDUCE study, which was a Gore study, and the CLOSE study, which was a study from Europe looking at a bunch of different devices. Again, all those three studies were positive. Again, this is the RESPECT trial with the longer follow-up, 5.9 years, showing that risk reduction. Again, there was a low incidence of atrial fibrillation and flutter in the device group, but it also occurred in the medical group, and that p-value was actually not significant. There was a higher incidence of DVT over time in the patients who were treated with the device, and that's not unsurprising given that, again, we're manipulating in the vein. The REDUCE trial, again, as I explained, a similarly designed study with the Gore occluder, again, excluding other mechanisms of stroke, and their mean follow-up was 3.2 years. And there was, again, a significant difference between the closure group and the antiplatelet group alone. Again, there was a higher incidence of atrial fibrillation in the device group, which ended up being significant in that study with that device. The CLOSE study, again, a study from France that was including many different devices, also excluding other mechanisms of stroke, again, showed a significant difference between the PFO closure group and the medical arm. So we had those three randomized trials, and then finally in JACC 2018, a high-risk PFO trial was published, the so-called Defense PFO trial. This was 120 patients with prior stroke and PFO that had high-risk features, the atrial septal aneurysm that I explained before, a hypermobile septum or a large PFO with a septal excursion that was very large. Again, mainly these were patients 18 to 60 years of age, but actually 13 patients were older than 60 years of age. And this, again, showed a very significant difference. None of the patients in the device group had recurrent stroke, whereas 6 patients in the medical arm did have stroke. So basically, we have 4 positive trials. All the patients were studied mainly between, I shouldn't say all, most of the patients that were studied were between 16 and 60 years of age, and the benefit appeared to lower the baseline risk from about 1% per year to about 0.5% per year in those groups. And we did conclude with the Defense PFO study that in high-risk PFO, the benefit may be even more. But we also learned that excluding other causes of stroke is very important. There seemed to be a signal for increased risk of atrial fibrillation with the Gore occluder, but not with the Amplatz PFO occluder, and the procedural-related complications are low. So the current US guidelines for patients 18 to 60 years of age, again, the American Academy of Neurology initially had been cautious in terms of their recommendation and has become more supportive of the need to close patients that have PFO and stroke, especially in those between the AHA and then the SCAI are even more strongly in favor of that. Again, those are cardiology groups as opposed to neurology groups, but that's the current landscape for 18 to 60 years of age. The latest literature for patients greater than 60 years of age, I'm going to let Dr. Ostojic talk about more. But again, there is some data out there that this therapy potentially can be extended to this older, to a slightly older age group. And the current US guidelines for patients more than 60 years of age, again, the American Academy of Neurology is saying that PFO closure may be offered in patients to 60, 65 years of age with a limited degree of vascular risk factors. And again, the cardiology groups are saying basically the same thing a little bit more strongly. The European guidelines for patients greater than 60 years of age are a little bit stronger even for suggesting that if you've excluded other causes of stroke, and especially in high-risk PFO, that PFO closure is may be indicated. I'm going to stop there, and I'm going to turn it over to Dr. Ostojic to give her neurology perspectives.
So I'll be talking today about how the recent data has changed the way that I think about PFO closure in those over 60 years of age and how my practice has changed. So when it comes to stroke, we know that the prevalence of PFO is significantly higher in stroke patients than in the healthy population, as Dr. Love mentioned, especially so in those under 60 years of age. About 45% of patients with embolic stroke of undetermined source, or ESUS, have a PFO versus about 25% of healthy patients. Dr. Love also mentioned in the introduction that the majority of the positive PFO closure studies that showed a reduction in stroke recurrence after closure mainly included patients under the age of 60. So one of the most important arguments against closing PFOs in the older patients is that they are more likely to have other occult stroke mechanisms, even when a PFO is discovered. For example, atrial fibrillation, atrial cardiopathy, or atheroembolism from aortic arch atheroma, for example. And there's potentially a higher risk of de novo atrial fibrillation in older patients after closure. And then with a low risk overall of a PFO-related stroke, closure may be considered futile in a patient who is not necessarily expected to live many more years. But when we look at arguments for closure in older patients, we know that strokes are overall more common in older patients, and that includes cryptogenic strokes. We also know that right-sided pressures are more elevated in older patients, which may increase right to left shunting. And these patients are generally at increased risk of venous thrombosis as well, which can potentially then lead to paradoxical emboli. So knowing that life expectancy is increasing worldwide and that potentially life quality altering stroke could be prevented, should we maybe consider closure in carefully selected options? So when I evaluate a stroke patient who also has a PFO, I take multiple factors into consideration. The first question to ask is whether the stroke appears embolic. The main clues will be seen on brain imaging. Embolic strokes will often be cortically located. They can be multifocal, at times involving multiple vascular territories at the same time. And sometimes the specific vascular territory will also give a clue. For example, a stroke within the anterior choroidal artery territory tends to be more likely to be embolic. And then I look at the risk factor profile for the specific patient. So there are scoring tools that can be used for this, such as the ROPE score, the Pascal algorithm, and I'll talk about those in a little bit. I also look for specific features on the patient's echocardiogram, notably if there's any atrial cardiopathy or a very low ejection fraction, which would suggest that there's a competing cardiac etiology for the stroke. And then finally, the patient age is a consideration, as typically closure would be considered in somebody under the age of 60. So let's look at a typical, or a case that represents a typical patient or typical candidate for PFO closure. So this is a 49-year-old man with no known past medical history who woke up in the morning with acute right arm weakness. His MRI shows an infarct, an acute infarct in the left frontal lobe involving the motor cortex. This patient did not have any significant vessel disease. A TEE with a bubble study showed a large PFO with an atrial septal aneurysm, and he had hypercoagulable labs drawn that were unremarkable. So here we have a young patient who has an embolic stroke of undetermined source and no other vascular risk factors. So it's a pretty straightforward case for a good candidate for PFO closure, and his PFO was closed. So let's look at the scoring tools that can be used in these cases. The ROPE score, or risk of paradoxical embolism score, is a 10-point scale in which higher scores reflect a younger age and the absence of vascular risk factors. This score estimates the probability that a PFO that was discovered when working up a cryptogenic stroke is in fact the cause of the stroke. A higher score means a higher probability that they're related. And so, as I mentioned earlier, an older age does increase the likelihood of other etiologies being present, such as occult AFib. So that would make a PFO-related stroke less likely. Now, all patients over 60 will have a maximum ROPE score of 6, and data has primarily shown a benefit of closure in those with a score greater than 7. And then we have the Pascal algorithm, or the PFO-associated stroke causal likelihood. This combines the ROPE score with the high-risk PFO features to determine a causal relatedness. And the high-risk PFO features are a large shunt and atrial septal aneurysm. So this algorithm places patients in 3 categories: unlikely, possible, and probable. Now, all patients who are older than 60 and have high-risk features, they will end up in the possible category, only because their ROPE score will never be above 6. So what about patients over 60? What data do we have? So Eichelman et al. Published their results from a retrospective study in March 2024, looking at 342 patients over 60 years of age with a cryptogenic stroke and a PFO on TEE. So all of these patients were candidates for closure. 199 of them underwent medical therapy after refusing closure, and 143 underwent closure. The mean follow-up time was 5.5 years. They found that the risk of recurrent stroke was significantly increased in the medical therapy group, so it was reduced in the closure group. And there were very rare peri-procedural events, but those included bleeding, DVT, and infection. Wang et al. Also published their results in May 2024. This study estimated stroke recurrence risk and relative reduction in the event rate associated with PFO closure of patients over 60. And the goal of this was to plan and power a future clinical trial in this patient population. They looked at data from the ROPE and Oxford Vascular Study databases, as well as pooled individual data from the 6 randomized controlled trials in the SCOPE consortium. They found that when selecting older patients with high-risk PFO features, there was about a 50% anticipated relative reduction of recurrent stroke. So with this in mind, let's look at another case. This is a 64-year-old man with without any past medical history, who was on the subway when he experienced sudden onset right-sided weakness and numbness, right hemifield vision loss, and speech difficulty. He received IV thrombolysis with tenecteplase and went from an NIH stroke scale of 6 to 1 for just a right upper quadrantanopia. His vessel imaging did not show any abnormality. His MRI brain showed an acute infarct in the left medial temporal lobe, and his TTE revealed a large right to left shunt and atrial septal aneurysm. His left atrium was of normal size. He had some other workup. There was a hypercoagulability workup that was negative. He had no atrial fibrillation on EKG during his admission, was not found to have hyperlipidemia, diabetes, or hypertension. His calculated rope score was 6 because of his age, and he was in the Pascal category possible, as mentioned before. Now, this patient underwent PFO closure despite his little bit older age after undergoing this complete stroke workup that was entirely unremarkable. He also, of note, had a loop recorder implanted for long-term cardiac monitoring. And then a final case I wanted to show is that of a 63-year-old woman with past medical history of hypertension, non-small cell lung cancer, DVT on rivaroxaban, who presented after developing acute left-sided weakness, causing her to fall in the shower. Her CTA showed some mild left cervical carotid artery disease. Her MRI of the brain showed scattered acute infarcts in both cerebral hemispheres and the cerebellum, also known as the 3-territory sign, which we know has a high specificity for malignancy-related hypercoagulable states. The TTE showed a large PFO with atrial septal aneurysm. And so in this case, we have a patient where we highly suspect a hypercoagulable state. We know that patients with cancer can have multiple possible etiologies for their strokes. They include non-bacterial thrombotic endocarditis, paradoxical emboli via PFO, in situ thrombosis, or rarely tumor embolism. Now, PFOs become important in these patients because up to 20% of patients with cancer will develop a venous thromboembolism during their lifetime, and this then will increase their stroke risk if they also have a PFO. There's also a high recurrence rate of thrombosis in these patients despite systemic anticoagulation or antiplatelet therapy, so more aggressive management might be necessary to prevent stroke and hopefully help maintain a better quality of life, even if in those with a prognosis that is uncertain. So this specific patient underwent PFO closure, was also switched to therapeutic low molecular weight heparin for presumed DOAC failure. So so these cases highlight some of the situations where I would consider closure in patients over 60, essentially someone with a high likelihood of PFO-related stroke or high risk of stroke recurrence from paradoxical emboli. And safety data from existing trials suggest that this can be considered, and hopefully we'll have trials in the future looking at this specific population. All right, Dr. Love.
Great. Thank you so much, Dr. Ostojic. I learned a lot from that. I'm going to give you a cardiologist perspective for PFO closure, especially in patients greater than 60 years of age. And I'll show you a few case examples. So this is a first case example. Again, this is a typical patient. This is a 44-year-old woman that presented with dizziness, diplopia, and left-sided weakness. She was diagnosed with a cerebellar stroke and given TPA. She actually needed a craniectomy for worsening cerebral edema, but she ended up doing well from a neurologic perspective. Her workup was negative except for a TE showing a PFO. She had no diabetes, was a non-smoker, no prior stroke, and no hypertension, and her rope score was 8, and the attributable fraction was 84%. So she underwent PFO closure in November of 2016, and this was actually the first FDA-approved PFO closure in the United States. She ended up getting discharged to rehab on aspirin, and she's done well in follow-up. I'm going to show you how we do this in general. We typically do this with sedation, with intracardiac echo guidance, femoral venous access only. We don't do hemodynamics. We just evaluate the PFO by intracardiac echo, and we close it. And they typically go home the same day on aspirin indefinitely. And we will typically give them Plavix for 1 month as well, longer if they have migraines potentially. If you'd like to watch a PFO closure, for those who don't do PFO closure, if you'd like to see one sort of from beginning to end, if you Google my name and PFO closure on YouTube, you can see I do one from beginning to end. There aren't parts that are cut out, and it takes about 15 minutes in this video. I got 23,000 views already, so I'm pretty happy with that. I'll just tell you that my son rides King Dakar at Six Flags in Jersey, and we like to compete. He only has 18,000 views, so I'm pretty happy. This is his hair before, this is his hair after. I'll tell you that they just recently took down King Dakar. They imploded it because they're going to build an even taller roller coaster. So we'll have to go for that. And this is when he was about 9 years of age, and he's 19 now. So we typically use intracardiac echo. Again, it's at least as good, if not better, than TE, because you're right next to the atrial septum. When you look, it goes through an 8 or a 9 French sheath. And we get views that look like this. Again, as opposed to TE, the thing closest to the probe is the right atrium, and the left atrium is further away from the probe. Here you see the foramen ovale. This is septum primum with an aneurysm bouncing back and forth. And when we do a bubble study, you see the big bubble wash coming across the PFO coming into the left atrium. So we typically cross with a wire, put the sheath out, deliver the left atrial disc, pull it back snug against the septum, deliver the right atrial disc, and when we're happy it's in good position, again, we look with the intracardiac echo, and then we just unscrew and release the device. And then this is what it looks like with the bubbles afterwards. It's negative. This is a case example of a slightly older patient. This is a 64-year-old who fell off a ladder and suffered a pelvic fracture 2 weeks prior. He had an IVC filter placed prophylactically, and the patient subsequently had a stroke with hemifacial weakness, and a TE showed a PFO with atrial septal aneurysm. I just want to show you here, this is the IVC filter, and you can see here the negative contrast. This is clots on the IVC filter. And I just wanted to point out that, again, an IVC filter is not like cheesecloth. When we're talking about preventing stroke, again, this will prevent a huge DVT that potentially could be life-threatening in terms of a pulmonary embolism, but will not prevent stroke. As you can see here, we still have significant clot, and if a small piece breaks off and goes across a PFO, that can continue to be significant. So we actually did PFO closure in him. We actually went transhepatic through the liver rather to avoid going through the IVC filter. It's very difficult to do PFO closure from the SVC. It's potentially possible, but it's hard because it's actually directly posterior. So it's actually hard to get through a PFO from the SVC. So we actually went transhepatic through his liver, closed the PFO. He was treated with warfarin once he was ambulatory, and 6 months later, we took out his IVC filter, and he had no clot in the IVC filter at that time. Here is a third case that I just wanted to point out. This is a 45-year-old with a new cerebellar stroke, and he was found to have a left lower extremity DVT, and an IVC filter had been placed a week prior. He had a negative transthoracic echo, but it showed late bubbles, and he was on IV heparin. We actually ended up bringing him to the lab rather than doing a TEE prior. It actually happened to be the Friday of the Thanksgiving weekend, and trying to get a TE was pretty difficult, so we just decided we would do that. So we brought him to the lab with the intention of closing the PFO. We actually saw this huge clot coming up from the IVC, going through the tricuspid valve into the right ventricle. Here you see the atrial septum here. You see the clot extending all the way down the IVC. We did a bubble study, and it was negative at that time. I was not brave enough to do a Valsalva because I didn't want to see bubbles going across, and then showing you that picture that I showed you before with the clot caught in transit going across. So different people would do different things. There are clot evacuation devices that potentially you could use percutaneously, but I was just concerned about that in terms of potential risk for embolization, especially in the setting of a PFO. So we actually sent that patient to surgery, and he had a pulmonary embolectomy. You can see the stuff that was taken out of the right and left lung, and this was the clot that was taken out in transit. They did actually find a PFO at the time, and they closed it. He was anticoagulated with Lovenox and was discharged 3 weeks later to rehab, and he's done well, and I've seen him in follow-up, and he's doing well. The point being is that I think that you have to be thoughtful about PFO closure, especially in different circumstances. From the perspective of PFO closure in patients greater than 60 years of age, from a technical standpoint, it's really not different than younger patients. there's potentially a concern that you may need to cross the septum later for interventions in the left atrium, potentially left atrial appendage closure or an AFib ablation or potentially a mitral intervention. People talk a lot about that. As it turns out, again, these things are fairly unusual. Now, again, if the patient doesn't have AFib when they're 65 or 70, maybe they'll have it when they're 80 or 90 and they'll need something done. It's potentially true, but not very common. Having said that, there's plenty of atrial septal real estate left to cross inferior for the device for these procedures if you need to do anything. You can cross through a device if needed, but it's more difficult, so I wouldn't recommend planning it that way, but it's certainly possible. Again, if AFib ablation or left atrial appendage closure is being contemplated in addition to PFO closure, I would recommend doing those procedures first, just because why make something hard when you can do it when you can do it easier? And again, sometimes we will do that as well. But again, I would just point out that it's not like, oh, well, you put a closure device and now you can't do any other procedure in the left atrium. It's not true. PFO closure and transvenous pacemaker or ICD leads, I want to point out, there was this paper that was published not long ago that showed 6,000 patients with transvenous leads. 364 had a PFO and they were followed, this is from the Mayo Clinic, they were followed for a mean of 4.7 years. And stroke was actually much more common in patients that had a PFO, 8.2% versus 2% in non-PFO patients. And again, I think that that's an important consideration. Again, these leads all get debris on them, which is basically thrombus, and it's often right next. It's going through the right atrium, but typically right next to the atrial septum. And it's not surprising that sometimes you can have debris embolize and potentially be a higher risk for stroke. So again, a number of patients that are older than 60 will have pacemaker or ICD leads. And again, something that I certainly consider in terms of weighing the factors going in for PFO closure in an older patient. So my impression for PFO closure in patients greater than 60 for device selection, the Amplatzer PFO occluder is probably preferred over the Gore occluder in older patients because there's that signal for atrial fibrillation post-closure that's higher in the Gore occluder, and the atrium is more vulnerable in older patients to arrhythmia. So I think that that's an important consideration. So in conclusion, device closure of PFO for PFO probable related stroke has been proven in 4 trials to be beneficial in decreasing the risk of recurrent stroke over medical therapy alone in patients primarily 18 to 60 years of age. It's unlikely to be able to feasibly do a randomized controlled trial, as Dr. Ostojic pointed out, in patients that are more than 60 to prove efficacy of PFO closure over medical therapy. But in carefully selected patients more than 60, PFO closure is probably beneficial, especially in patients that have high-risk anatomy, that have a strongly positive bubble study, lack of a more convincing stroke mechanism, presence of transvenous pacemaker or ICD leads. And again, as you can see from the simplicity of PFO closure and the low risk of complications, it becomes it becomes an easier decision when you're talking about a relatively low risk procedure to potentially reduce the risk of what can be a very life altering event that is a subsequent stroke. So, we had a question that was posed to us: how do we work together in terms of a stroke cardiology brain team? And I think that that's an excellent question. I know that there are some centers that actually have formal clinics where they see patients together. We don't do that typically. It doesn't seem to work so well for our workflow. Most of the patients, of course, I think see Dr. Ostojic first. They will have seen a neurologist first. And then are referred. I will also see some patients that are referred to me by other neurologists, and if there's a question, I will definitely send to Dr. Ostojic for another opinion. As it turns out, from an insurance standpoint for PFO closure, most of the insurances definitely require a letter or a note from a neurologist saying that they think that it's a PFO probable stroke. They require imaging showing that there actually was a stroke, and concurrence from the cardiologist that they have a PFO and that closure is warranted from a cardiology standpoint. Do you want to comment a little bit from the patient flow standpoint, Dr. Ostojic?
Yeah, so I agree. Most of the time, I will see a patient in my clinic and do complete the workup, and then reach out to Dr. Love, if I feel like this is a PFO-related stroke, and a lot of times ask for advice regarding evaluating for a PFO, or we might already have some evidence that there might be a PFO, and then just making sure that you agree with that. And but we do also work a lot on the inpatient side, where some of our patients that are admitted with acute stroke, we end up finding PFO, and then we sort of start that collaboration already on the inpatient side. And it's usually a very smooth process.
One of the things that I find that's very important in all this is actually looking at the imaging itself. The imagers here seem to have a very low threshold for calling. They've got a template, and it basically says, they talk about opacification of the left atrium with bubbles. And opacification means you can't see through it. I actually think it's not a great term that they use. And when you actually look, there's, that you may find that it's really it looks like a very benign study. And so again, in a patient who we think is more likely to be PFO related, in a younger patient where they really don't have other risk factors, we'll be much more aggressive in terms of looking at that patient, maybe doing a transcranial Doppler, making sure that they get a TE, the transcranial Doppler with bubble study, and really looking. Whereas in a patient that seems to have other risk factors or another mechanism that may be more likely, we may not be as interested in investigating as strongly when they have other stroke mechanisms.
Completely agree. And then I think, speaking of these a little bit older patients, it becomes even more important to make sure that we really looked at the imaging closely, and to know if there are high-risk features, for example, if we're going to take that into consideration when considering closure.
Yeah, I definitely think that the high-risk features on a PFO, if you have a very strongly positive bubble study and a very hypermobile septum, that actually really sways my feeling that PFO should probably be closed as a high-risk PFO patient. So, Dr. Ostojic, I wanted to ask you that the value of the ROPE score in Pascal, I think you touched on it a little bit, but the problem that I see with those scoring systems is we would really like a crystal ball to be able to say, was this PFO, or what was the cause of this patient's stroke, and was it related to the PFO? And I think one of the problems with these scoring systems is for the patients where it seems obvious, where they're young, they have no other risk factors, and they've got a PFO with atrial septal aneurysm, a strongly positive bubble study. That's sort of an easy call. You don't need a scoring system for that. And for the older patient with multiple risk factors for stroke and a PFO that is trivial at best, we probably don't need a scoring system for that patient either. It's the patients in the middle where we're sort of stuck a little bit. We don't really know. And the dilemma that I have is that all of these end up as sort of possible in the middle kind of things. And so I don't find that it necessarily helps, in the sense that we kind of knew that was the problem. How do you deal with that?
Yeah, you're completely right. I mean, I think for most patients, we rarely actually use the scores formally. We talk about them, and they're helpful in teaching our trainees and kind of to think about, the different aspects to considering a patient for PFO closure. It is sort of a logical. They're very logical scales and scores, right? Because we know what we're looking for. We're looking for a younger patient with no other risk factors, and so that only helps us, but to kind of prove that by giving it a number. But it's not necessarily. It's not very helpful in those patients where it's a little bit more complicated. So I think there really it's just about looking at the whole patient. I don't think that we have a score that really helps us there yet. And we really just have to look at so many different factors, like I mentioned. Are there other things that make this more complicated, and where we feel like closure would be helpful in the very specific case that we're discussing. And that's where it's also so important to have this collaborative approach with cardiology, and just being able to talk about the patients together and figure out what the best approach is.
I think, when I work with you and hear you discuss with the trainees and such in the conference room and stuff, I think that a lot of it also is how much value, you can have all these different things, but it's sort of how much weight you're putting on on each of them, and I think it's an individualized patient thing.
Absolutely.
You can say diabetes, right? But there's diabetes with a hemoglobin A1C of 15, and there's diabetes with a hemoglobin A1C of 6.1. And I think that again, some of the, when you say smoking or smoking history, it's like, yeah, I smoked a cigarette once when I was 20 versus, I continue to be a 2-pack a day smoker, up to my 70s. I think those things, those subtleties end up being lost a little bit in the scoring systems. That again, I think when you find other things that aren't necessarily formally included in the scoring system, like they have significant other vascular disease, for instance, then it makes it less likely to be PFO. Whereas if you're really finding an absence of other vascular disease, that again, this is somebody who's more likely where the PFO is more likely to be causative.
I agree. And then there are some cases where we would maybe normally anticoagulate a patient, and there are a lot of situations where that's either not safe or feasible, or we anticipate that there will be problems with anticoagulation going forward. And maybe those are cases where we should also consider closure as an option to again help prevent a stroke, which would be really devastating.
Sure. And again, like I said, our experience with PFO closure, the fact that we're not doing it with anesthesia, that we do it with just local anesthesia, we have a very, very low incidence of complications, I think has lowered the bar in terms of, well, if we can eliminate that as a risk factor, PFO is a risk factor, I think it potentially can be helpful. It makes the decision a little bit easier when you're trying to figure out what to do. So thanks everyone for listening. I think that this has been a really excellent discussion, and I know that I've learned a lot speaking to Dr. Ostojic as well and hearing from her. Again, I think just to summarize, there is some data in patients greater than 60, not a huge amount, but with that and with clinical experience from cardiologists and neurologists that are trained in the field, I think we can make pretty reasonable decisions as to the benefit of PFO closure in patients greater than 60 years of age, and select patients that potentially would benefit from that therapy. So with that, I thank you for your participation, and I think we'll conclude there.